Good morning, everybody. My name is Wayne Kubal. I practice at the University of Arizona, and I'm going to talk about head and neck infections this morning. Now, you might be sitting there and going, hey, man, I'm a general radiologist. I don't like head and neck infections. And that's fine, but you can't really escape them. You know, head and neck infections come into clinics, they come into emergency rooms, they don't necessarily go to the big trauma centers. You can't very well, ignore a neck infection for 6 hours until your shift is over. So, whether you like them or not, you're probably going to have to deal with them. And I'm going to spend the next half hour making it a little bit more comfortable in dealing with these cases. Our learning objectives are really very straightforward. We're going to learn to diagnose neck and face infections on CT, typically a contrast-enhanced CT. We'll characterize the nature and the location of the infection. That sounds like a pretty reasonable goal. And then I'm going to take you one step further because these infections can have complications. And if you can anticipate those complications, you'll be ahead of the game. You'll do a better job for your patients, and your clinicians will love you even more. So when we talk about the location of the infection, that means we need to learn a little bit of anatomy. And you're going, my God, we're starting the meeting with anatomy, and well, I hadn't planned to start the meeting, but here we are. And when I was putting this talk together, I went to an ENT textbook, and they pointed out that these infections are really contained by the cervical fascia and the spaces they define. And I've drawn those spaces in for you, but unfortunately, there's not an app for that. You can't push an easy button and have that pop up on your CT scanner. So how are we going to learn this anatomy? Well, you can't really see the cervical fascia unless I've drawn them in for you, but I'm going to teach you the anatomy based on the contents of each space, which I think is probably a better way to learn the anatomy. Let's start with a really easy one. Next time you're standing in front of a mirror, open your mouth, go, look in the back of your throat. Look behind that pink hanging down thing. That's your uvula. Look behind that, and you're going to see mucosa. That is the mucosa of the pharyngeal mucosal space. And then just deep to that mucosa is lymphoid tissue. And you can arbitrarily divide that into tonsils and adenoids and all that, but it's just a big blob of uncapsulated lymphoid tissue. And I've shown that in sort of a mustardy yellow here. Here's a case of acute tonsillitis. You're going to see this every night in a busy ED. Note that the uvula is swollen and enlarged, and the tonsils are pretty symmetrically enlarged. So you need to get comfortable with what normal tonsils look like on your CT scanner and in your population. They're enlarged, they're enhancing, and to tell you the truth, if you missed this, it really wouldn't be the end of the world because your job is to look for suppuration and spread to other spaces. And the reason that it's not such a big deal is I'm showing you the clinician's view of the tonsil. You see the uvula there in the midline, and then you go off to the patient's left, which of course would be our right, and you see that big swollen red tonsil. So if you go consistent with tonsillitis, you're not telling anybody anything. They already know that. What they want to know is, how are you going to characterize this infection? Is it cellulitis? Is it an abscess? What's going on below the mucosa? Because all they're seeing is the mucosal surface. So let's have a look at the CT. You see that there is an enlarged tonsil. You see that there is a poorly defined, poorly enhancing focus within that tonsil. That is typically cellulitis, or localized tonsillitis, if you will, and some edema. This is what we're talking about. Sorry to show this so early in the morning, but you can see that this patient has a well-defined fluid density collection with an enhancing wall. And come on, everywhere in the body, this is an abscess. And in the tonsil, this is a peritonsillar abscess. These are typically aspirated right in the emergency room, and the aspiration is good because it shortens the course of the infection, and it also provides some material for culture and sensitivity. Sometimes you run into this. This is a later stage abscess, and you'll notice that its imaging characteristics are kind of between the full-blown abscess and the cellulitis that I showed you. There's a collection, but the wall looks like it's kind of collapsed down on itself. And unfortunately, a lot of times these people come into your emergency room as well. And although they won't always tell you this story, most typically this was an abscess. The patient was put on antibiotics. The patient felt better, threw away the antibiotics, and then the infection recurred. And they didn't want to go back to their original emergency room because that would be embarrassing. So they come to your emergency room. Thank you so much. Always good to have patient volume. So let's recap. Cellulitis versus abscess. If you see something that's poorly defined and low density, we're dealing with cellulitis. And I hope your communication with the ED is really very good, because you don't want to say normal or nothing going on here. You want to make sure that you let them know that this is slam dunk infection. If you see fluid density with an enhancing wall, you tell them it's an abscess, and then it's up to them whether they want to try to aspirate it or not. Our accuracy is not great. I reviewed several series of both pediatric and adult patients, and the CT accuracy was 63 to 77%. But as I showed you in those clinical images, the clinician has no clue. Really very, very difficult clinically to assess whether that tonsillitis has suppurated and you have an abscess, or whether it's just cellulitis. And the distinction, of course, is important because the treatment is different. Let's move to a new space. This is the retropharyngeal space. I've outlined it here in orange, and you can see it's got a little bit of fat in it. This is an adult, and so we're not really seeing any nodes, but sometimes you'll see some fairly prominent nodes if you've got young children, let's say under the age of 5. The space is divided by a median raphe, and that gives it kind of a bow tie appearance, and that makes it easy to pick up. And why am I spending so much time on the retropharyngeal space? Because it extends all the way to the mediastinum. So it is a super highway for bugs that want to come from a common infection like a tonsillar infection and go all the way down to the mediastinum. Let's have a look at a case. So clearly we've got an infection in the pharyngeal mucosal space. Look at the right tonsil. But now look posteriorly. You see all that edema back there? That's edema within the retropharyngeal space. And if you look at the image on the far right, I think you'll appreciate that bow tie appearance. Let's keep tracking it. And we track it and we track it, and clearly you can see it's extending to the mediastinum. So I don't have to tell you that this patient needs more imaging. If you want to see the entire extent of the infection, you're going to need a chest CT. Okay? So what is your job? When you identify a tonsillar infection, immediately look to the retropharyngeal space to see if you have edema there. If you have edema there, your job is to follow it south until it either becomes normal or you get to the mediastinum. So pretty easy to do. How about this case? Well, the pharyngeal mucosal space, at least on the images I'm showing you, looks pretty good. I think I would pass that. But you see that telltale fluid posteriorly? Is that a retropharyngeal space infection? Bit of a problem. Well, let's look a little bit further, and I'm going to show you the key. The key is to look for calcification just below the anterior arch of C1. And of course, you can see it on the axials. You can see it on the sagittal reformat that I'm showing you. This is calcific tendinitis. These patients will typically present with neck pain and low-grade fever, And it's very, very difficult to separate out, clinically at least, the calcific tendinitis from a neck infection. But if you remember to look for those calcifications, you can make the distinction. And I'm sure I don't have to tell you that calcific tendinitis does not respond terribly well to antibiotic therapy. Okay? Patients do receive some relief from nonsteroidals. Okay, let's move to the masticator space. It's kind of an easy one. It contains part of the mandible, muscles of mastication, and given that anatomy, the infections in this space are often odontogenic in origin. And I don't know about your ED, but man, everybody in my ED has bad teeth, and that can lead to a lot of infections. Let's start with a confidence builder. This is an easy one. If you look at the bone windows, you can see that this patient has had an extraction. And then if you look at the soft tissue windows, look at the right masseter muscle. You see it's enlarged. Those of you who are good at looking for dirty fat, just look in the buccal fat adjacent to the masseter muscle, and you'll see some fat stranding. The masticator space infection. And you're right. We're going to look very carefully to make sure we don't have an abscess, but this is just an uncomplicated infection. How about this case? All right, patient's got some left-sided tenderness. We look over on the left. Yep, pretty big involvement of the masticator space. But what I did was I played with the windows a little bit. And looked very carefully at the mandible. And if you look at the mandible, you'll see a little bit of air within it. And so always play with your windows. You can go directly to a bone window. You can sort of, scroll through various windows, which is typically what I do. And certainly if you see gas within an adjacent bone, you're dealing with a bigger problem because you definitely have osteomyelitis. Okay. Does this person have a masticator space infection? Well, came in with right-sided facial pain. That was certainly one of the considerations. The radiologist looked at it and he said, yeah, well, there's a little bit of schmutz there in the sinus, but there's thickening of the wall. This is just some chronic stuff. And they said, yeah, well, sorry your face hurts, but go home. Patient comes back several weeks later. Oh, it's going to be a learning experience, isn't it? Could we have done a better job? Did the radiologist kind of blow this one off? I'm going to share with you an anatomic pearl that's going to make you that much sharper in picking up these infections. And that is, what you want to do is you want to interrogate the pterygopalatine fossa. And I've blown this up. The pterygopalatine fossa on the patient's left is normal. You see the fat in the fossa, and you see the fat sitting just behind the maxillary sinus. Have a look on the patient's right. You can see that the fat is either infiltrated or displaced, and so there is a deep space infection that was not appreciated by the radiologist. How much did the patient suffer from that omission? Well, let's have a look. Here's a series of CTs. These are all done on different dates, and you can see the infection is just getting worse and worse and worse. You can see now that the entire masticator space is involved. If you look anteriorly, you'll see that there's some early suppuration. They tried to drain that. It wasn't the easiest area to get to. They got a little bit of juice back. The infection continued to get worse and worse and worse. His entire face was swollen up. They finally got control of it, but not until, again, use your bone windows if you need to, not until the patient developed deep face osteomyelitis. So, word to the wise, interrogate that pterygopalatine fossa. Okay? You can also look at the retroantral fat. Probably not a bad idea to look at both of them. And that's going to make you that much smarter than the radiologist who made a miss on this case, and you can see how the patient suffered. Okay, let's go to the parotid space. And you go, yeah, well, I know about the parotid. It's the parotid gland, and there it is. I want to make you into analytical animals when it comes to looking at the parotid gland. And easy enough to do. Look at the density of the parotid gland, and you'll see that it is denser than the adjacent fat, but it is less dense than muscles of mastication. And that relationship holds whether you're doing a non-contrast CT or a contrast CT. Is that really going to help us? Well, in a case like this, not so much, okay? You don't even need this lecture to say, yeah, this patient has left parotitis. What about this case? We were chatting before about, trying to read things at 3 in the morning. This comes through facial swelling, 3 in the morning. I don't know. I've missed stuff that's more obvious than this at 3 in the morning. This patient's got bilateral parotitis because you're analytical enough to look carefully at the density of the parotid glands. And so you're able to make the correct diagnosis. You can get stones in the parotid gland. They are more common in the submandibular gland, but there you go. Let's move now to the carotid space. And things start to get pretty interesting in the carotid space. For one, it contains carotid artery, jugular vein. Those are pretty important structures to be able to evaluate. And those vessels can be very easy to see if you have IV contrast. So as much as you possibly can, really put your foot down. If people are worried about a neck infection, you need to do a contrast-enhanced CT, none of this non-contrast stuff. And then for completeness, cranial nerves 9 through 12, at least a portion of those cranial nerves pass through the carotid space. Okay, here's a case. How are we going to interrogate the carotid space? I'll tell you what, let's start on the patient's right side. And this is what I do. I start laterally. And of course, the first thing you run into is the jugular vein. So find the internal jugular vein. And you can see, for one, that the lumen is filled, the fat around it is normal. What I'm doing is I go for the jugular vein, then I move medially. I look at the fat between the carotid and the jugular. I evaluate that fat, and then I look at the carotid. Okay, everything is fine. Let's go over to the left side, and you'll see that the internal jugular vein is clearly abnormal, right? You can see that it's thrombosed. Notice that the wall is enhancing. If you thought that it might just be a bland thrombosis, well, clinically you might have some indication that people are worried about infection. And then on imaging, if you look at the fat within the space, you'll see that the fat is abnormal. Let's look at the carotid artery. You can see the carotid artery may be displaced medially just a little bit, but at least it's widely patent. Okay, so we've got jugular septic thrombophlebitis. And remember I told you that these infections can spread. So if you were a chunk of infected thrombus in the jugular vein, where would you go? You know that. You go to the lungs. This is an example of Lemaire's syndrome. Now, by definition, Lemaire's syndrome doesn't have to have thromboembolism to the lungs. The second most common place to go are the major weight-bearing joints, but you can't very well, image every joint. But it wouldn't be a bad idea if you encounter a patient like this to ask the patient, how are those knees and hips holding up? But even a neuro guy can tell you this is an abnormal chest. Okay, let's up the ante a little bit more. I mean, come on, we're just playing with veins. Let's look at carotid artery. Okay, we're going to start on the right. You can see that there is a right carotid infection, right? You're tuned into that. You start with the jugular vein because we're starting laterally, and you can see that there's infectious thrombophlebitis in the right jugular vein. Should we quit there? Boy, I hope not. Let's blow things up. There's the abnormal jugular vein. Let's blow things up. What do you think of that carotid? We're pretty far down in the neck, so this is going to be the common carotid. You see that funny little outpouching medially? There it is. That's not mini-me That's a carotid pseudoaneurysm. Okay? Why? Why in my emergency room, in my hospital, I have to deal with a carotid pseudoaneurysm? Well, infections tend to have proteolytic enzymes. Proteolytic enzymes go to work on the wall of the carotid artery. They weaken the wall of the carotid artery, and it starts to pooch out. And that is a post-infectious carotid pseudoaneurysm. Now, don't go looking at ankle films when you've got this thing up on your board. Put everything else aside, get on the phone, get a hold of your colleague in the ED. And if he or she doesn't seem to be really getting it, if you say, your patient has a carotid pseudoaneurysm, they go, oh, thank you very much. Just say, and that means that your patient is at risk for imminent carotid blowout. That usually gets their attention, at least in my experience. And because, part of our job is to not only make the diagnosis, but communicate the diagnosis to somebody who may not be very specialized in head and neck. Okay, let's have a look at the sublingual space. I've outlined it here in blue. I'm going to kind of talk about the sublingual space and the submandibular space together because they are right next to each other. They are separated by the mylohyoid muscle. Okay? This space contains a portion, actually, of the submandibular gland. Of course, it contains the sublingual gland. And because it extends to the anterior mandible, you can also get a odontogenic infection. Here's a nice example of an infected fluid collection within the left sublingual space. You see how it's medial. You see how there's enhancement. And you can actually see that there's a little bit of lateral displacement of the mylohyoid muscle, which in this case is enhancing because it's an infected fluid collection. You can get infections in the sublingual gland. And it's one of those things where you kind of have to know where to look. You're zooming through your axial images and you notice some asymmetry. You go to your coronals and you can see that the sublingual gland is enlarged. It's enhancing a little bit more than its counterpart on the right. And there we are. And of course, you can have a sublingual abscess. I don't think you'd have any trouble calling this an abscess. You guys are pros. But you want to get the location right. And to get the location right, I recommend using the coronals. You can see how the mylohyoid muscle is pushed downward and laterally just a little bit. This is clearly above the mylohyoid muscle, and that means that the abscess is in the sublingual space. Really important, particularly if this is going to be surgically drained. You want to get it right. Okay, let's look at the sister space now, the submandibular space. It's inferior and lateral to the mylohyoid muscle. It contains the bulk of the submandibular gland and associated lymph nodes. And for those of you who are in the lymph nodes, I know we're going to have a lecture later this morning. These are going to be the level 1B lymph nodes. And I'll also show you an example of an infected second branchial cleft cyst. I've outlined that space here in sort of a dark forest green. And here's an abscess in the submandibular space. Do you see how it's lateral to what we were seeing in the sublingual space? You can have stones. They're fairly common, but oftentimes they migrate out of the submandibular gland and get stuck in Wharton's duct. Here we are. Here is a big cystic collection that is infected. This is a congenital lesion. This is a branchial cleft cyst that became secondarily infected. And you can notice it by its location. These, because they're congenital lesions, are always anterior and deep to the sternocleidomastoid muscle. This one's a little tougher, and I'm using old terminology here. These are venolymphatic malformations. I use the term cystic hygroma, which is an old term, but it reminds us that this is cystic, it lists fluid density, and these can become secondarily infected as well. and unfortunately can't give you a good anatomic clue because these can occur anywhere in the head and neck. Let's have a look at a case. We see swelling over the right face. Where is it coming from? We see kind of a funny floating root in this tooth. And this is basically endodontal disease. You have a cavity. It spreads to the pulp chamber. It spreads to the dental roots. It exits at the root of the tooth and sets up a localized osteomyelitis, endodontal disease. Common, at least in my ED population. And, you can see that cyst in any projection you choose. Endodontal disease. How about this? Soft tissue swelling over the forehead. See a little bit of sinusitis. Well, we got hosed when we didn't pay attention to sinusitis before. We're not going to make the same mistake. We're going to look really carefully, including intracranially, because this infection is not only spread to the forehead, spread to the brain. We have a small subdural empyema, and first described by our friend Percival Pott, who also described Pott's disease of the spine. Now, these sinus infections can spread to the forehead. They can also spread to the orbit. How do they spread so easily? Well, we have kind of a design flaw we were born with, and that is that the veins that drain the paranasal sinuses are valveless veins. And that means when you build up pressure within the sinus, the infectious material within the sinus can spread to all the adjacent organs, brain, orbit, forehead, spread all over the place. Last case, penetrating trauma to the left orbit. You can see that on the CT. This is a tree branch to the eye. Clinicians really wanted to know if there was a retained foreign body, for pretty obvious reasons. We looked as hard as we could with CT, couldn't find it, but we know that wood can be difficult to see. 3 days later, the eye is obviously infected. You can see there's a small abscess developing. And the clinicians are really on our case. They're going, you've CT'd twice, you can't find it. We know there's got to be something going on there because we have loaded this patient with antibiotics. We go, okay, well, we know there's not metal in the orbit, so we feel good about doing an MR. Here's the MR. You see on the contrast-enhanced MR, I'm showing you here on the right, you can see that abscess that is developing. But it turned out that the sequence that helped us the most was the T2. There's the sliver of wood. I got to tell you, I've gone back and forth on this case. Impossible to see on the CT. But we picked it out on the MR. They were able to remove the sliver of wood, get control of the infection, and actually save the eye for this patient. So in summary, I've given you some clues about how to identify infection and shared some anatomic pearls with you. We learned how to characterize infection, specifically to differentiate abscess from cellulitis. And then we learned some anatomy about how to localize the infection, not only the space of origin, but spread to additional spaces. We recognize some of the complications. Use those bone windows if you want to pick up osteomyelitis. Obviously, you want to look pretty darn carefully at carotid and venous structures. And then appreciate underlying abnormalities that may predispose to infection, like an obstructing calculus, dental procedure, endodontal disease, which is rampant in the ED, congenital lesions, like a branchial cleft cyst or a cystic hygroma. Well, we went a little bit out of order, but I thank you for your kind attention so early in the morning, and I wish you the very best of good luck in dealing with this very challenging group of patients. Thank you again.